welcome to a very, very special Hope podcast. Today we are lucky to have Dr. Assad. Welcome, Dr. Assad.
Thank you for inviting me.
Thank you. So as a starter, please give us a brief about the scope of pediatric orthopedic surgery and how you came to be a pediatric orthopedic surgeon.
Well, I was interested in orthopedics during my medical training. I think the aspects of, there's quite a lot of maths in orthopedics and engineering principles, and that appealed to me. I like looking at something as a structural or a mechanical problem, because much of like general surgery, I know it sounds really glamorous when people think about like heart transplant or doing aortic surgery, but the reality is much of surgery is like fixing one pipe to another pipe, whether it's an artery or a vein or a ureter or bowel. It's essentially fixing a tube to another tube.
Yes.
But what I like in orthopedics is that you operate on bones, you operate on joints, you operate on tendons, you release nerves. So there's a lot of variety. There's a lot of scope for variation. So you could be operating on a foot and then you could be operating on a knee. So approaches are different. There's lots of different techniques. So we use lots of different types of implants inside the body, implants outside the body.
Yes.
So it appealed to me on lots of levels. I like pediatric orthopedics mainly because it's the most challenging area of orthopedics. So I think if you like a diagnostic challenge and also challenges in terms of treatment, pediatric orthopedics is there, because there's no joint replacement. There's very few simple solutions for complex problems. Complex problems usually demand complex solutions, often staged treatments, and then you have to take into account the fact that the child is a dynamic situation. I mean, they are growing.
Sure.
Their bones are changing.
Yes.
Everything is changing. So you have to factor that in, that what you do, how will it change with growth? Is now the right time to do something? Is it better to do something later?
Yes.
Are things going to get better with growth or get worse? So I think pediatric orthopedics I found very challenging and academically rewarding.
Yes, and it's very, very, very special. I think that when the skeletal system, it is what carries everything else. So when you modify something, everything, the alignment, the way all of the body is moving is different.
Yep.
And as you said, the children are growing, they are moving from one point to another. So at a certain point, you are managing this situation, but when you move to another situation after 6 months, it can be a totally different picture.
Yeah.
Yes. Okay. So for children with cerebral palsy, I believe that for as you have said, like looking at their feet, at their knees, at their hips, when we look and see different issues that they face. Sometimes the feet are going in more than they should be, going out more than they should be. So, that's what we call like flat feet, like varus. Sometimes there is an equinus deformity, a calcaneal deformity. Knees are going in or out. So different and the different problems. And then sometimes, or most of the time, you have more than one problem to face at the same time. So I believe that it's this decision about which problem you will go in first or address first. It's difficult to decide.
I think it is very difficult, and I think what is very good about physiotherapists is I think sometimes physiotherapists are more holistic than orthopedic surgeons are, because ultimately you can't just say I'm just going to treat a foot and ignore the rest of the child. Whereas it's very easy for surgeons to be like that, to kind of just focus in on one problem and a deformity and just think I need to do something with this. Because as orthopedic surgeons, primarily our interest is in a deformity. We look at something almost as being a bit static and the wrong shape, and then we want to make it the correct shape. But how does that take you to improved function is something that it's very difficult to extrapolate.
Yes.
And I think the good thing with physiotherapy assessment is that it's very holistic for the children, and looking at movement as a whole, and spending much more time assessing and treating these children means you have a far better insight into what the problems are. So I think you need kind of like a close-up approach, but then you also need to be able to step back and like see the child as a whole.
Sure, very important point, and of course, relating all of that in to the function as well is very, very important. Daily functions of children and the parent and the child goals, what they want to do for themselves. Great. So, can you tell us what are the most common surgeries that you do in pediatric orthopedic field?
Generally, or like in cerebral palsy?
In cerebral palsy.
Cerebral palsy is very interesting because the practice has continued to evolve right up to the present day, and it continues to evolve further. So if you look at what was being done 10 years ago, 20 years ago, it's very, very different. People might say that for most of medicine, that how we treat things are changing. But I think in the field of cerebral palsy, the development has been far greater. And I think that's because cerebral palsy is a lot more of a complex challenge. So the essential deficit, like in cerebral palsy, is that there's a brain injury early on in life, and it leads to an impact on movement and posture. Yes. And therefore it's quite complex in that every child is affected slightly differently in terms of their movement and posture. So we do have classification systems, classifying children based on function, classifying them on how much of their body is involved, classifying them in terms of the neurological phenomenon. Is there unwanted movements? Is there tightness of muscles? Is there weakness? So it's a very, very complex, diverse condition. And then as a result, the scope of treatments is very, very diverse. And almost always it's multimodal. So it's, every treatment program for a child where there is surgery, by necessity will involve physiotherapy. It usually will involve orthotics, and lots of other different specialities. So in terms of the surgery, what we had traditionally was dealing with the problems that we see. So the muscle is tight, and then we will release the tendon. The muscle tightness, if it stays long enough, it will induce a deformity in the bone. So the bone may rotate outwards, it may rotate inwards, it may bend. So then attention can then be thought about correcting the bone. In children who are quite severely affected over time, even the joints may start to dislocate or distort. So there's an abundance of problems, and therefore there's lots of strategies. The sad fact is that often surgery introduces problems as much as it solves problems. And I would say that in the field of cerebral palsy, the biggest risk that there is as when you consider surgery is that you will make the child worse than they were before functionally. You may improve a deformity. The knee may be straighter. The ankle may be more flexible, but the gait may deteriorate. And traditionally, a lot of the operations that were done before, they're still done, to this day. Tendon lengthenings for important power generators or stabilizers of joints. They're still undertaken. Now, I think the focus really is on controlling the initiating event, because the initiating event usually in cerebral palsy is the increased tone, the spasticity. And if we can manage that earlier and better, then that avoids the consequences you have of that increased tone. So the tightness, like I was saying earlier, muscles initially become tight. Over time, they become contracted. Once they're contracted, they start to pull on the bone, and the bone distorts, and over time, joints distort.
Yeah.
So that whole cascade, which is usually made worse by growth, because as the child grows, things become tighter and the whole process is accelerated. If you can stop that early on by controlling the tone, then that's very useful. And I think, selective dorsal rhizotomy has been, I think is one of the big things that I think has improves management of tone in these children at a younger age.
Yes.
Traditionally, Botox was offered to a lot of children and is still done to relieve tone, but it doesn't have that enduring benefit that you would see, say, from selective dorsal rhizotomy. Yes. Ultimately, I think even with the best intentions, children with cerebral palsy who walk will almost always need surgical intervention. I think to improve their gait. I think children, as they grow, inevitably problems arise. So I think it's very hard, when I see parents, if they say, I just want to avoid surgery throughout my, child's childhood going up to adult life. And I say, well, you can, but if we were to optimize their gait and make their gait as good as possible as they transition to adulthood,
yes,
then really there is surgery along the way.
Yes.
What the surgery is very specific to the child, but there's no way of, I think, of kind of just avoiding that and saying, we won't have to do anything.
Yes. So what are the risks or benefits of these surgeries and the expected recovery time regarding the most common ones that are done for children with cerebral palsy?
So generally, the children with cerebral palsy, if we had to look at them as two groups, generally there's the children who have walking potential and walk, and then there's children who do not have walking potential and will be wheelchair users. So if we look at the gross motor function classification system, which I'm sure you well know, levels 1, 2, 3 are fairly good function, and these are children who have walking potential, and then 4 and 5 are wheelchair users, and the needs are different. So generally, the severely affected children, the priority is comfort. So a child who has total body involvement, often increased tone, so usually spastic dystonia, and is a wheelchair user. The problems you have with these children is that over time, the muscle tightness and contractures makes it very difficult to look after them.
Yes.
So if the hips become contracted, the pelvis distorts, they develop scoliosis, and these deformities become more and more fixed. It becomes hard for them to sit. It becomes hard for them to lie comfortably. It becomes hard to wash and dress them.
Yes.
So really, comfort and pain relief are the important reasons to intervene in these children and do surgery. So typically the surgery that we think about in these children is surgery for hip problems and surgery for spine problems. It's not that we don't address feet in children who don't have walking potential, but usually it's not the foremost concern.
Yes.
The biggest issue is the hips can progressively dislocate because of the tightness in the muscles. As that happens, the pelvis starts to distort and it affects their seating posture. So they can't sit straight. And once they can't sit straight, then the scoliosis starts to progress.
Yes.
And the two, in essence, the hips and the scoliosis kind of feed each other and create more problems. So the surgery that we consider for those children is really hip surgery and scoliosis surgery. But it's not without risks, because generally the more severely affected children will have multiple medical problems. So often they have poor respiratory reserve, history of chest infections,
Yes.
Poor nutrition, occasionally epilepsy. There's the risks are quite great, but we know that if we don't address these problems in these children, they will only get worse. They're not problems that stay static or regress. They only get worse. So it's a very difficult conversation with families when a procedure has risk. And the risk from in hip surgery, the general risk of complications is around 25%. Most of that is minor things, pressure sores or chest infection following surgery. But then the severe ones, need to be on ventilation, blood transfusion, fracture, residual hip dislocation, metalwork problems, wound care problems. They're thankfully less common. So that's one group.
Yes.
The other group, the children who walk or have walking potential, it's very important, and I'm sure you know this, is that we have to maximize it. Yes. So even if we can get a child who can stand to transfer as an adult, it's still much more independent than a child who cannot stand to transfer. So any benefit we can gain in terms of their mobility is very important for their adult life. Because generally, children with cerebral palsy who have walking potential, they will go into adult life and they will have like a normal lifespan.
Yes.
But what we have to think is about the burden of disability for like 40, 50 years of adult life. So the better we can make them as children going into adult life, the better it is for them, for that lifespan. And sometimes it's very difficult for everyone to see the utility or the benefit when you are going to do a very big procedure for maybe, say, a 20% improvement in gait efficiency. You're going to all this effort. There's months of physio. There's like a long operation, and the child is still not going to walk normally afterwards. But you've improved the efficiency of the gait. It's looking better. They can walk longer. But I think the real difficulty is for people to understand that benefit. And understand why we do so much for not marginal gains, but not the kind of dramatic gains that people think, that surgery should achieve. And that's one of the problems with a child with cerebral palsy. The parent says, my child walks and has just, limited walking capacity, and you're going to this major surgery. Will they walk normally? And you're like, well, no, it will be a lot better. And the parents are like, well, they still need an assistive device. And you're like, yes, they will still need an assistive device. So it's difficult. It's difficult. So
I believe that the decision making about it is very different than when we are dealing with children with only orthopedic or musculoskeletal problems like a fracture or something. It is far more complicated when you have the neurological impairments, which make a lot of differences in the way muscles move, the coordination, the way the body is supported. And I believe that the term that is bringing the two groups together in the gross motor classification system is the quality of life. So for the levels 4 and 5, which are wheelchair users, the quality of life for them would be easier care, better pain management, less pain, to be able to sit pain-free without any deviations, without any problems, because for all of us, sitting is our main position throughout the day. So it's very important for them to have that function pain-free and for longer times. For the other group quality of life also can be for them when they go into adolescence, to go to school, to be able to walk for longer distances, to improve their energy conservation, and like minimize the energy expenditure for them. For a girl, it can be like to be able to go to the prom, or like to be able to, yes, to go out with her friends. So sometimes it has most of the time it has social aspects to it. It has psychological aspects to it. So that's why families and the child as well have to be involved in the goal setting, and that's why 20% can be for them very big, and they want to do it more than the surgeon or more than the team. Yes. So but for some cases, sometimes surgery is a must. You have to do it.
I mean, it's very interesting you said this about the goal setting and what is important for patients. And sometimes what I find is I'm surprised the other way. Is that you do a surgery and you have a huge treatment program and you have lots of physiotherapy, and then you see the gait analysis before and after, and you say, well, it is better. Yep, it is. But I did this girl once who had crouch gait, and she was a marginal walker, GMFCS3, which means assistive devices, holding onto a frame. And she was in crouch, and her feet were bad, her knees were bad. And because she was a marginal walker, like 100 meters with her assistive device, then a rest, I thought, I can't do everything, so we'll manage the feet with splints, but I'll correct her crouch. I'll make it so that her knees are straighter. When she was walking, the graphs showed from the analysis her knees were bent at 45 degrees. And I thought, if we can get that to like close to 10 degrees or even straight, then it will be better. So she had surgery to both of her knees, and I also did some to her hips. And she spent months in hospital, and she had lots of physio. And when she came out, she was still using a frame, but you could see she's walking better, the knees straighter. But when she came to see me, she was over the moon. And I said, oh, that's really, really good. She said, no, you don't understand, Dr. Qureshi. I feel taller. Like, you straightened out my knees, and I'm now almost 20 centimeters higher when I'm out and about. I feel like I'm taller. And it's the best feeling in the world.
Gives you goosebumps.
And she was like, for her, it was such a big thing. It was such a big thing. I think she felt, and I never thought about that actually when we do surgery for crouch gait, we're improving the patient's kind of vantage point, how they see the world. I mean, like we never think about that this person is crouched, so they are seeing the world from 20 centimeters down from where they might be. So it's like you say, is, the goal setting, and for everyone to understand what we're aiming for, and having a common goal, patient, surgeon, physiotherapist, orthotist, everyone, I think is really crucial for good outcomes.
Sure. So when is it contraindicated, or like you want to do the surgery but you cannot do it for a specific patient? I know these moments are difficult.
They are, because sometimes it's very upsetting when parents come and they want their child to be better, and they're actually very keen on treatment. They're like, if this takes surgery, whatever the surgery is, we want our child to be better. I think the basic problem we have in orthopedics is, what can we treat and what can we not treat? So with cerebral palsy, you have added effects and you have negative effects. So the added effects are things that shouldn't be there but are there. And then the negative effects are things that the child should have but doesn't. So the positive effects are usually the increased tone. So that's the main one, the increased tone and the tightness. And then there may be excessive movements, unwanted movements. So those are examples of positive effects, things we don't have, but these children have. The negative effects, it's mainly weakness and loss of selective control. So even though muscles are tight, it's quite hard for people kind of like understand this unless you've seen this child and cared for this child, understand that the muscle is tight, yeah, it's weaker.
Yes.
You know,
Yes.
so it's a and in orthopedics, the muscle tightness, the consequence of the muscle tightness in terms of the bone deformity and the joint problem, we can fix, but we can't boost the strength.
Yes.
Or the selective control. So if, the really difficult ones, and almost certainly you'll have seen these patients, is when you have patients who have no contractures, they have very good muscle power and no deformities, but they're in a wheelchair because the injury to the brain has affected their control of movement. So there's no voluntary purposeful, coordinated movement. They will move their limbs, but they can't walk.
Mm-hmm.
So there's nothing you can do surgically in that instance for that child,
Yes.
because the problem is to do with the brain's control of movement.
Yes.
That's nothing orthopedic. So when patients have weakness, that's a big issue. And I think an orthopedic surgeon should recognize that and realize that some patients, they will not be able to take the hit of a big operation and a lengthy recovery period with the amount of power they have.
Mm.
And it's a very difficult assessment when you examine these patients. And what I usually do is if I see them walking with an assistive device like a frame, the question I have in my mind is, how much weight are they using from their upper limbs? Are they really supporting their weight? So then what I will do is I will walk them again, but holding my hands for support. Then I get the feeling, is it balance, or is it really they need their upper body strength to make up for the weakness in their legs?
Yes.
The other group is where there's cognitive impairment.
Mm.
So you have a child that may not understand what's happening to them, and therefore will not comply with the rehab and may be very distressed by the surgery. Or once again, they may be very cognitively able, but there may be circumstances in the family, there may be circumstances in their personal life where you feel they won't engage with the rehabilitation. And I think I had a case of a young man who could walk, but he was in severe crouch. And I was trying to convince him that, I think, look, as you go into adult life, we should do something about your crouch, because it is important in adult life that your gait is as good as possible. But the problem is he'd found his dignity in like being in a wheelchair and doing wheelchair sports.
Yes. Yes.
And he was like, well, no, I'd rather be in the wheelchair and do the wheelchair sports, and I don't want to have this big surgery. And that was very difficult, because, he could understand. He could. And I think this is where, as a surgeon, you will not have as much interaction with the patient as other members of the team. And, and therefore I think I would never embark on surgery without having an interaction with the therapy team and saying, this is what I'm thinking. And usually what I will do is, if I don't know the therapy team personally, then I will give them a copy of the medical report and say, this is what I'm thinking, but I want you to go and share this with the therapy team and give my contact details to the therapy team, because I need to know what they think. They may think this is the best idea ever. They may think it's the worst idea ever. So I think, for the question about, which patients is it where you start to think, surgery is, I think the problem is where there's weakness, significant weakness. Yeah. Then that's something you can't, and that's the main problem with gait. That's not something you can address. Yes. And the other problem is patients' willingness to comply with complex treatment programs and lengthy rehabilitation.
Yes.
Yeah.
Yeah. I believe also that like this child that you're talking about, who preferred the wheelchair, he preferred independence. Yeah. It's better for him to be independent, doesn't need help, doesn't need assistance in a wheelchair, rather than taking an assistive device, walking for a specific distance, and then he will need the help of somebody for transfers. He will need the help of somebody to carry his equipment for him.
Yep.
So yes, independence is very, very it's one of the main aims for this whole program. Of course. What are the most common fears or misconceptions from parents that they have when they come for orthopedic consultations?
I think one of the biggest challenges I have is when it comes to any type of complex treatment, naturally, parents will want as many opinions as possible before embarking on something complex. They will want to, see different doctors have different opinions. And I think one of the most difficult things is when they see a doctor who's not necessarily it's their specialization or focus of interest, and then they may get an opinion which actually is detrimental almost. And I mean, the one that I've come across a few times is there will be a child who is in a wheelchair with a progressive hip dislocation and having more and more pain and becoming more difficult to look after. And the issue is they will go to see a doctor and an orthopedic surgeon. The orthopedic surgeon will say, I won't be able to make your child walk, even if I put the hip in. So you have to decide the merits of whether it's worth doing.
Yes.
And I mean, I have heard it, and I've even heard this from like pediatric orthopedic surgeons say, which is the reason it's very detrimental is because we don't do hip surgery in these children to enable walking potential. We do this to make them comfortable and make the life of the caregiver easier. And I think for the children who are in the GMFCS categories, 4 and 5 wheelchair users, one thing we don't, I think, appreciate enough is caregiver burden. We think about a child and we think, okay, the child may be uncomfortable from their hip dislocation. And, that's not nice that they're in pain. But perhaps they're not in pain much of the time and they're okay in their seat. And we can continue with non-operative treatment because there are risks with operative treatment. And as long as the child is kind of kept still, they'll be okay. But what we don't think about is that this child has a caregiver who has to wash and dress them.
Yes.
And especially, when there's contractures, I've had parents tell me that it takes both parents to wash the child after they've gone to the toilet, because one parent has to hold the legs open because they just clamp shut, whilst the parent is washes. I think for me, I had one patient which really, I didn't think this at the time. I think I was quite early in my career. I had a 14-year-old girl who came from Romania with a neglected hip dislocation. She was a GMFCS 5 in a wheelchair. And I think they'd had a few opinions, but everyone was like, and she developed a mild scoliosis. They came to see me and I said to the parents that I think we should put the hip in. And they said, well, other doctors said there's no point because she's not going to walk. And I said, no, but I think for her comfort and you look after her, it's important. And then I said, is she in any pain? And they said, well, she doesn't communicate. She just grimaces a bit. And I said, is it a problem like washing and dressing her? They said, it's okay. We can manage it. And I said, well, the reality is we don't really know how much discomfort she's in. And I can tell you that this is a progressive problem and therefore we should do it. And the parents were in agreement. They said, okay, doctor, we'll take your recommendation. So I reconstructed her hip. And then I put her in a plaster to keep her legs apart for 6 weeks whilst everything healed. And then they came back at 3 months, 6. And the mum was over the moon. Yeah. And she was like, Dr. Qureshi, thank you. And I said, yes, it's good. I'm glad you're grateful. She said, no. He said, you don't understand how much you've changed our lives. And I said, how so? And she said, you asked me whether my child was in pain. And I said, I don't think so. And she didn't really seem in pain. But the reality is that she wouldn't sleep through the night before.
Yes.
So she would lie in a position, and then at some point she'd cry out, and we'd have to turn her and move her. And then we'd go back to bed, and then it would happen again. And she said, me and my husband have not had a full night's sleep in like years. And we both work jobs, and it's very difficult. She said, since you've done the surgery, she sleeps through the night. As a family, we all sleep through the night. No one wakes up. And then before the surgery, she said, she wasn't comfortable enough in her seat for us to go anywhere. You should have like a maximum tolerance of 15, 20 minutes. Then we'd have to stop, and you would have to lie her down or change her position. So we really couldn't go anywhere far. Yes. But since she'd done the surgery, she can sit comfortably in a chair for like an hour and a half, no problems at all. We can now go places. We can actually see friends, see relatives we haven't seen in a very, very long time. And I never thought about these things. I mean, at the time when you do the surgery, you think, I'm going to take this child, avoid them having pain, avoid them having problems. But it's a very real issue that a lot of these children, as they get older, their parents who are the caregivers, they're getting older.
Yes.
It's very hard to lift up a contracted teenager, and care for and wash and dress, a teenager with severe deformities and contractions. And aside from that, all of the children who have these progressive deformities, they inevitably get more and more chest infections, more and more problems, more and more hospital admissions. It can really dominate the caregiver's life. This progressive deterioration which happens, and it's all musculoskeletal in its origin. That's the thing, it's like, primarily something we look out for and something we can do something about. But it has a massive impact on not just the patient, but everyone around them, everyone who looks after them.
Yes.
So for me, I think, being able to communicate that to a family, is sometimes very, very difficult when they've just had this child with progressive deformity for years and they've become used to it. Like that family had that I described. When I asked them before the surgery, did you have any problems? They were kind of like, no, because they've kind of used, it becomes their normal reality of looking after a child like that. So I think one of the biggest issues I have is parents having the appropriate advice. And what I say to parents is, you really should read and go on the internet, and there's lots of very good information to help guide decision making. But I think the biggest issue is a lot of parents are deterred from intervention.
Yes.
And they may even be led to believe that that's an acceptable point. That's an acceptable management. To not do anything for these problems. And I think that's wrong. That's wrong. If that information is being conveyed, or the parents feel that that's an acceptable position to have, is to not do anything.
Yeah. Sometimes definitely it is a risk. It's like they came into this journey since the child was born, maybe, and they are living this way for years, and they don't have the idea that there's something better that can happen, and there is a different life that they can live, and it's too much risky. Sometimes it's too optimistic for them, that they think about it a lot before doing it. So and there comes the awareness, and the reading, as you said, that they have to read. Every parent has to study their child's condition, what are the available options, research it, go everywhere, because there are many options that can help and make their life easier, the families, the parents, and the child as well. So when should families consider going to an orthopedic surgeon?
I think that's actually quite a difficult question, because like we said, that the problems that evolve, at what point would you say they need orthopedic surgery? I think the best system is where a team works together. And what we know from like Europe, where they've had registries and collected lots of information on patients, and they've found out what these problems are and how they develop, and they've created systems of surveillance to look out for problems. Because the reality is that if you can, as a therapist, you will be seeing a patient regularly, but you can pick out when that problem is coming.
Definitely.
Or it's happened.
This is number one.
then that's actually the best system of knowing when to see an orthopedic surgeon, rather than me saying, come every 6 months or 3 months and I'll see your child and just check everything's okay. If there's a good communication with the therapy team, everyone understands the goals of treatment. Everyone understands like a traffic light system of, are we green? Are we amber? Are we red? Green, everything is fine. Physio is going well. Child is flexible. Amber, there's tightness, but no deformity. We can up the physio. We can try some other postural management. Red, there is a deformity. Yes. There is a problem. Yes. The hip is this. So I think the best advice I'd give to parents is have a team-based approach for your child, where everyone is communicating with each other and everything is coordinated, so that you limit visits. Because that's one thing that I know, that these parents with children who have cerebral palsy will have lots of hospital visits, and what you want to do is minimize that. So if I have, like, for instance, you're looking after a patient and doing their physiotherapy and their postural management, and you're seeing them regularly, you could say to me, at some point, Dr. Qureshi, the abduction range in the hips, the ability to move the knees apart, is reduced. I'm worried there may be a hip subluxation or evolving problem. Can I send them to you for an X-ray? And then they may come to me, we may do an X-ray, and then the hip is dislocating. And then we could say, well, then now we have to think differently. Or I may do the X-ray right back to you and say, the X-ray is fine. I think everything is fine. We can continue. But if there's anything else. So I think a coordinated team approach gives you the best outcomes, and also minimizes clinic visits as well, importantly, which means that, parents are not always seeing people again for the same thing, So, so I think every patient should be in that network. And I think therapy teams are excellent gatekeepers. They know the child better than the orthopedic surgeon will. They know when things are changing. They know when things are responding to treatment. They know when things are not responding to treatment. And then the best relationship then is between the orthopedic surgeon and the therapy team. Sometimes parents may want to come directly. They may say, I'm just not, something's happened. I want you to take a look at this, and that's fine as well. But for me, you can have regular visits to an orthopedic surgeon, but much of it will be surveillance, where you're saying, I think everything is fine. And therefore, and if that child is receiving routine physiotherapy and seeing a therapist who can do the same assessment, I don't see the merit in like doubling visits.
If it is clinical, then the therapy team can check it out, and then when you have a team that trust each other and share a common framework, then you can build from there. But we have also some red flags when we talk about hips, when we talk about spine, some things that when you see, then we need an urgent intervention. for hips, maybe when you see that the internal rotation can be much more than external rotation. The child's legs are fixed in a specific position. When you try to straighten the legs, you for parents, if you try to straighten their legs, then you feel pain. They cannot sit in the normal position. They are shifted in one side. Sometimes also it's the deviation. You can see it when you see scoliosis. It's also noticeable for parents as well. So these are some of the red flags, right? So do you have any other recommendations for parents? Some things to look for?
I think you're right about, there are certain points where you say this is definitely worrisome. Like if there's a scoliosis in the child and you find, well, I can't lie them straight. If I hang them up from under their arms, the spine is not straightening out. There has to be some fixed problem. That's an obvious one where we think, okay, we probably need to see someone. Like you said, with the hips, is if there's a windswept deformity. That's classically what you'll find is one leg is out and one leg is in.
So
and then you can't kind of bring them out together or straight. That's definitely a problem. I think the most important thing is having thresholds for referral and thresholds for intervention that everyone agrees on. Because it's a real issue, for instance, if patients get conflicting advice. And that's the hardest thing I find is that, there's a problem developing with their hips. And often I don't think therapy teams will think we'll continue with the physio. For this fixed deformity. But then the problem is if you do the x-ray and the hip is starting to come out, but then it's felt that maybe we can do something else like a brace that maximizes their position or Botox into muscles to kind of relax the contracture a little and make the child a bit more comfortable. The problem then is that that's not solving the problem. It's kind of prolonging the problem. So the important thing I think parents have to appreciate is they will always want less done. If they're told, for this hip problem, we can have some Botox to make the muscles a bit more relaxed. Or there'll be a major surgery to correct the hips, then they will all choose the former. But what parents have to understand is what is the correct decision. And I think the scale of intervention, it puts off a lot of people. And what they're looking for then is a simpler solution. And I think the problem is from orthopedic surgeons is that we shouldn't adjust our decision making to what parents want, because parents will always want less. But that doesn't mean that we offer them ineffective treatment. So I think the classic one is for gait problems is hamstring lengthening. It's really something that's fallen out of favor. I mean, anything that affects power generators for gait, is not really a good idea. But tendon lengthenings are still done because they're simpler options to present to parents, and parents will want to choose something that is less invasive. But the reality is for all these children with their pediatric orthopedic problems in cerebral palsy that need treatment, there's usually a very strong recommendation for a specific treatment. It's never a case of we could do this or we could do this or we could do this. And I think this kind of presentation of kind of less invasive treatments that are actually ineffective, or they just prolong the problem. They kind of temporarily alleviate some elements, but they just kind of prolong the problem. And I think that's the issue with red flags and thresholds for treatment, is that sometimes the red flags are recognized by the therapies team, but then the parents may not want to want the actual treatment, or they may sideline the physician into something lesser, or the physician may actually offer them something less, especially if the physician is risk averse. And one thing I would say about surgery for cerebral palsy is it's very much not for the risk-averse surgeon. Ultimately, many of these children who need help need high-risk procedures, and it does take a lot of strength from everyone to make those decisions, but it's always a shared decision.
Sure.
And what I've found is when I've spoken to families, is they don't dismiss the risk or absolve themselves of it and say, you're the doctor, you make the decision. But if something happens, I'll be very upset. Is they become shared decision makers, and it's very useful when you are doing high risk procedures. If there's a possibility of a bad outcome, and usually those are the cases where I've had is where there's a child who's in severe pain, but is actually quite unwell from multiple health problems. And then the question is do you embark on a major procedure with a lot of risk to their health and life, or do you leave them in pain? It's not reasonable to leave anyone in pain.
Sure.
And then it's a very difficult discussion. And I've found that parents will always make, in those circumstances, they will help you and you will make the right decision as shared decision makers, and you will both accept the risk.
Definitely.
So I would say this to parents, that when you have like red flag markers and your therapist refers you, you should have a collection of opinions. But you can't be fixated on having the least invasive option, because the least invasive option may not help your child really in the short term or the long term.
Sure. I believe that every voice should be heard. Like the voice of the parents, the voice of the child, the voice of the orthopedic surgeon, the therapy team, the physiotherapist, the occupational therapists when they are dealing with the positioning of the child, with their fine motor abilities, how they study at school. A lot of different inputs, the way they communicate with the speech and language therapist. Sometimes the orthotist might tell you that for this child at the age of 7-8 years, I can do a splint for him and it's allowing him to walk. But I'm telling you, once he reaches 10 years, the splint will not hold him up. The child's weight is high. The splint will not function as the same as now. So then the input, different perspectives from the team complete the picture, and then we are moving into the right direction. And also to know the limits of each intervention.
Absolutely.
Yes. So it's every specialist have to know the intervention that they are delivering, the limitations of it. When it's an advantage and when it cannot give the benefit anymore, and we have to move for something else.
Excellent.
So it's not good to have intensive therapy for 5-6 years, day in, day out, every day, and then eventually you will do the surgery. Well, then if you move it a little bit sooner, if it's the right choice, you will save a lot of your energy and a lot of time and a lot of pain. Definitely.
I think you're absolutely right with that, how you said it, is that treatments are complementary, not interchangeable. Not this idea of you can have surgery or physio. Which one will it be? It'll be like, no, you have physio at the right time and you have surgery at the right time for the right indications. And I think it is very important that parents understand, that like this, that they're not like separate things. It's not like we don't want surgery, we can have physio. And you're like, well, actually, no, you need both, because the surgery will likely enable better physio.
Definitely.
And sometimes you hear I remember once I was at a conference, I heard a very strange thing that was said, where they said that surgery for the foot in cerebral palsy is like an internal splint. Like there's an external splint, or you could do surgery, which is like an internal splint.
So different products.
Yeah, but they'll kind of make it seem like they're interchangeable options. Like, and you say to the patient, "What would you like? A splint on the outside or something?" But the reality is that when we think about foot deformity and like a splint and surgery, if something can be splinted, why would you operate? If it can be, often we undertake surgery so that the foot can be better splinted. Not to, it's very rare that you say, "Oh, we're going to do a surgery to remove a splint completely." That doesn't. It can happen, but it's not as dramatic as it sounds. But usually, what it is that the patient has a very big splint, a difficult splint. They may have a ground reaction force orthotic that helps control their knee extension, and then we do surgery to actually take them to a simpler AFO. So I think as long as, like you said, that parents understand that all these different treatments, you can't just choose one and not the other. They all complement each other, and they all have their indications, and they all have their right time as well.
Yes.
And I think with orthopedic surgery, like you said, why leave a problem to require more surgery and have a less predictable outcome, then do it earlier to enable better physio early on and better function. Yeah,
definitely. A very common question that comes from parents for children who are not able to walk or who could walk before and then stopped. Will surgery make my child walk?
There's a general answer to that one, and then there's probably a nuanced answer. The nuanced answer is that maybe in some select cases, but the general answer would be is that if a child can't walk, because children will walk in very adverse circumstances. Definitely. You will have seen it. The child has a severe flexed knee. A foot that's collapsing into a severe flat foot, but they're still standing, they're still walking. They may only walk within the confines of the home, but they're walking. So the issue with a child who doesn't walk at all, and you being able to deliver some treatment, like a surgery to enable that, is I can't really think of many instances. There may be times when children were walking better, and then have a very specific problem like a foot deformity that doesn't allow them to stand now. And they don't have access to splints or any therapy. And I have had children like that. They stopped walking because of a foot deformity that didn't allow appropriate stable base. And then you correct the foot and then they're back to walking again. But those are very rare instances. And I think I've never had it where a child never walked before, and then you've done an intervention and you've made them walk. So usually surgery is to preserve walking as children get older, to stop when they things may be getting worse as they get heavier and the weight to power ratio starts to shift unfavorably, especially in teenagers. So it's either to preserve walking or optimize gait. So the children, I find that, GMFCS2, with hemiplegia and a cavovarus or a flat foot, those have good outcomes in that you correct their foot deformity, their gait becomes a lot more efficient, looks better. The marginal walkers, often you're just trying to preserve their gait and optimize it a bit further so that they still have an assistive device, but they can walk longer. But I think that's one thing I would not want it to be on the product, is that you don't want to kill off people's hope.
Definitely.
But at the same time, you don't want people to have unreasonable expectations. That can't be fulfilled, because that's probably more disappointing.
Definitely.
For them, so.
Definitely. I saw a child once who was also walking on the top of his foot. So as you said, children will walk if they have the capacity to walk. They will walk in different shapes, different alignments. different ways. But if the child didn't walk before at all, some selected cases, some high percentage of them, that children that didn't receive proper treatment from the beginning. They didn't receive therapy, or maybe very, very little. Maybe the quality was not the best. Then the contractures or the musculoskeletal problems can appear at an earlier age. And then they cannot pick up the functional milestones, the functional activities as early, but they have the capacity. And this is where the decision making and the expert team can make the decision that this child has what it takes to walk, but the musculoskeletal problem is limiting the child from doing that. And this is one of the limited or selected cases that we see that, but it's risky. So it has
you're right.
Okay, so what is the best age for surgery for children who are ambulant? Or
one thing, it's a difficult question because it's changed. The answer has changed so much over time. I mean, there's a famous diagram from in the book on interpretation of gait analysis, gait problems by the James Gage from Minnesota. And this classical diagram it describes this kind of phenomenon called birthday surgery, where these children, they start and then they have problems with like tightness in their calf muscles, and then they have lengthening, then they have hamstring problems, then they have a lengthening. So they're having surgery at like so many points throughout their life for different problems as they evolve. More recently, there's been this move towards single event multi-level surgery, that you deal with multiple problems at one time. So there's one surgical hit and you get the child over it with intensive physio and rehab. The question was, when do you offer this? Previously, there was a belief that it would be nice to solve all these problems once they're static. So once a child is close to being fully grown and you know things aren't going to change anymore, then you could do everything then at that one time point. Fix everything. And then you know that in adult life. But then there was this realization that in waiting in that time from a child who at age 8 or 9 is starting to walk not great, and you're waiting till they're 16, they will have deteriorated quite significantly, and then you will have lost possibly the benefit of doing something earlier. So the age has always been variable, and for me, it's always depended on what the specific problem is. I found the higher functioning children, hemiplegia, GMFCS2, their problems usually will come on after the age of 10. And what is nice is to be able to, if you can do procedures which are less, rather than, so if the foot is flexible, but the muscles are out of balance, before a bony deformity can develop, if you can do procedures with lengthenings and tendon transfers, then that will avoid the need for bony surgery if you left that foot to get deformed and stiff. If it's flexible, but not doing what it's meant to, you can do some soft tissue procedures. But once it's become deformed and stiff, then we're looking at bony surgery. I would definitely say that the limits of doing surgery have moved younger now. I think before we would say that, we'll do these single event multi-level surgeries when children are older. But now I think to preserve strength and stop them, being set back, is to solve the problems early. I think under 10 it's a bit difficult because there's a lot of growth ahead of you and you're worried about tightness coming back. But I think around the age of 10, maybe a bit earlier, maybe a bit later, is actually a good time because a lot of growth is behind you. And then you can look at the scale of the problem. If you think this is a problem that if we leave it untreated, unoperated, no surgery, it will deteriorate in these few years such that we can't get that function back if we do something then, then it would be better to do something now. But there's nothing in pediatric orthopedics that is as complex and analog in the spectrum as cerebral palsy. You'll know this, is that you really can't compare any child in your care with cerebral palsy to any other child.
Definitely.
And so it's one of these things where it actually is very difficult to have general recommendations. Like when a parent comes and says, a lot of the time when I see children with cerebral palsy the first time, I have a tentative plan, but I say, can I see you again? And I'll see your child again, and on a different day, maybe they'll be feeling a bit different, motivation will be a bit different, to help with my assessment. Because it's very, very difficult, like when we see children compared to when you see children, is just that half an hour clinic visit, and trying to gain insight into everything.
The whole picture.
And think, can we do so? Is this the right thing to do for this child? This major procedure, are they going to benefit from it? So it's always a considered decision, and it's best considered over a bit of time. I think you should never rush this decision. No one should ever go to their pediatric orthopedic surgeon and come away immediately with a date for surgery, and we're going to do this.
I believe definitely this should be a take-home message for orthopedic surgeons, ones who are looking to be specialized in the field, the new generations of surgeons, I believe. I'm surprised that the time has passed. I didn't feel the time.
Oh, right. It has been actually very good, hasn't it?
Very nice. I didn't even cover all the topics that I wanted to talk to you. Yes, but definitely we will need to meet again and have another talk. It would be great. Thank you, Dr. Assad. Would you like to give a parent a take-home message for our parents?
I'd just like to say to all the parents that you're doing a wonderful job looking after your children, and the child and yourselves are the most important part of this equation, really, more than any kind of treatment decision or complex strategy, or and that's the most important thing. But it has to be very informed, and I think the best advice was, I'm going to repeat, is that being experts on your child as an individual, and their condition is probably the best thing you can do, really.